And get started. Thank you everyone for joining us. Welcome to the latest Duke media briefing on the COVID-19 pandemic. I'm Greg Phillips with Duke Communications. We have three Duke experts with us today to discuss the emerging strains of COVID-19 and what we can do to mitigate their spread, as well as the ongoing vaccination effort. With us today is David Montefiore. He is a professor and director of the Laboratory for AIDS Vaccine Research and Development at the Duke University Medical Center, where he has studied some of the emerging strains of COVID-19. Good morning to you.
Good morning, Greg.
Also joining us is Becky Smith. She is the Medical Director of Infection Prevention and Control and an Infectious Diseases Specialist at Duke University Hospital and Associate Professor of Medicine at the Duke School of Medicine. Good morning to you.
Morning, Greg. Thanks for having me.
You're welcome. And we have Jason 𝘉𝐸𝐴. He is Director of Emergency Preparedness and Business Continuity for Duke University Health System, where he is managing the logistics of the health system's vaccination effort. Good morning to you.
Good morning.
Okay, Dr. Smith, we'll start with you. Anthony Fauci has recommended wearing 2 masks to limit the spread of the virus. What do we know about the effectiveness of double masking in medical situations and out in public?
Yeah, it's a great question. So when thinking about double masking and the potential benefit of that and reducing COVID transmission, I like to break it down into what's happening in the healthcare setting, as that's my purview, and then what's happening in the community. We know after 11 months in the healthcare setting that our very robust infection control bundle works. So we're doing things like symptom screening. Everyone is universally masking using a medical grade mask that has standards applied for its filtration capacity and fluid resistance. And then we have a robust testing program to test patients on admission. We do some asymptomatic testing. And all of those things have been very effective at reducing the transmission of COVID within the healthcare setting. We've also now added the most important layer of this infection prevention bundle, which is the COVID-19 vaccine for much of our healthcare workforce. And so with all of those things together, the addition of a second mask may be less important than it might be in the community setting where we don't have these strict control measures in place, where you don't know if someone at the grocery store is symptomatic next to you. And so the double masking idea really is more layers of mask in front of your mouth, or the source of how you can transmit COVID, equals more protection. There are not actually any well-controlled studies that compare double masking to single masking, but again, there's some logical sense that an additional layer of protection would afford reduced transmission. I know the CDC has commented that they're now going to attempt to study this in a controlled way. And that will hopefully inform what happens with their masking guidance going forward. So stay tuned. I do kind of predict that there will be some forthcoming guidance coming from CDC on this. But for now, in the healthcare side, we're not forcing or mandating that our healthcare workers wear this, given that robust infection prevention bundle. If you're in the community setting, again, it might make sense to add this layer of protection. It's pretty easy to do, and medical masks are widely available at this point.
Gotcha. Thank you very much, Dr. Smith. Professor Montefiore, of course, some of this talk of double masking has come about as a result of concerns about new strains of COVID. What do we know about the new strains so far, and how concerned should we be about that?
Well, so first of all, let me say that it's no surprise that this virus is mutating. All viruses mutate, so that's something to be expected. What's surprising to scientists is how rapidly we're seeing this virus mutate, and for certain variants to spread in the population. Viruses need to replicate in order to mutate. The more opportunity they have to replicate, the more opportunity there is for mutations to arise and new variants to spread. And when you consider the fact that this pandemic has been going on as long as it has, over 100 million people who've been infected, they're known to be infected. The actual number is probably much higher than that. That's given the virus a lot of opportunity to replicate and to mutate. So, the appearance of these new variants is, in hindsight, something, that should be expected. And that's why there's been a very diligent effort to monitor through genetic surveillance. That effort was very strong early in the pandemic. It has dropped off in most places in the world, including the United States, towards the end of last year, but it's starting to pick back up again. What scientists are mostly concerned about are mutations that are occurring in the spike protein of the virus. This is the protein that sits on the surface of the virus and the virus uses to attach to a cell and get into a cell. It's also the part of the virus that's in all of the vaccines with the goal of generating antibodies that will block the ability of the virus to infect a cell. So the mutations that are occurring in the spike protein and in the what's called receptor binding domain in particular are what generate the most concern to scientists. And that's what we're seeing arising in these variants that are appearing in the UK and South Africa, Brazil, and now there's a variant that seems to be spreading quite a bit in California. And these all have mutations in the spike protein that are a potential concern.
Absolutely, thank you. And certainly we'll have lots of questions about the emerging variants, but for now, I'd like to move on to you, Jason 𝐓𝐴𝐶𝐞. Obviously, the emerging variants make it all the more important that people get vaccinated when they can. Duke has already administered thousands of doses of COVID-19 vaccines. What are some of the challenges you're finding that are posed by setting up vaccination sites to handle large numbers of people?
Sure. Yeah, it's a great question. I think that we've seen a lot of these mass vaccination sites in the news and just looking throughout our communities at a lot of our residents that are anxiously awaiting vaccination, which is a great thing. But these mass sites do pose some challenges for us, especially from the healthcare setting where we're not really used to doing mass sites. You know, we have to use this opportunity to collaborate with state agencies, local communities, outreach partners in order to kind of fill this big logistical need. I mean, there's a lot of requirements in terms of parking. We need to make sure that there's bathrooms at these sites. There's networking capabilities that we need to install. We also have to make sure that they're ADA, accessible for all of our residents. Beyond that, we also know that we're bringing a lot of people into, one area. So we have the obvious, concern of social distancing and not wanting to be a source of transmission. So there's a big piece right now that we have to go through to these sites and retrofit these areas to really, be able to provide some level of patient care. Also recognizing that within these larger sites like stadiums, raceways, parking lots, we do have residents and patients that cannot utilize these types of services. So how do we augment those locations with the traditional healthcare setting that we are used to seeing when we're trying to give a flu shot or something like that? So we really have to come at this from a multifaceted approach and not just be focused in on the one type of mass vaccination site. We want to make sure that we're as diverse as possible in our care delivery.
Absolutely, thank you. Okay, thank you all to panelists for those opening answers. We're going to open it up to questions now. Thank you to everyone who submitted questions in advance. We have quite a few of those, and I'm going to start there. But you can also post questions via the Q&A window at any time. If you'd like to ask your question in person, raise your hand in Zoom and we can unmute you when your turn comes around. And if you're calling in by phone, you can raise your hand by pressing *9. And panelists, any questions that come through the Q&A window, I'll ask them to you out loud, so you don't need to monitor that. Dr. Smith, I'd like to come back to you and to summarize a number of the questions we've had. People are asking about inflammatory responses that people are seeing to when they have the vaccine. What can you say about the responses that people have had to the vaccine and what that tells you about safety in general?
Yeah, absolutely. So a lot of people are curious, what will happen when I get my vaccine? What type of symptoms will I experience? And as with any vaccine, you can have a range of experiences. Oftentimes, the most common symptom people feel is a sore arm. And additionally, people have experienced fevers, body aches, kind of feeling fatigued, having headaches. Those are some of the most common symptoms people have felt. I'd like to spin those symptoms as a happy response, knowing that your immune system is responding to the vaccine and helping to build that antibody protection for you. So again, so far, the vaccine's been generally well tolerated. For those people that are having more moderate symptoms after their vaccine, a lot of people have wondered whether or not they can take Tylenol or acetaminophen or ibuprofen, and those are just fine, and they seem to mitigate those side effects pretty well.
Absolutely, thank you. Professor Montefiore, we've had questions about the interplay with new variants and the vaccine. How much do we know about whether the existing vaccines can provide protection against the emerging variants?
A very good question. And fortunately, there were results announced last week for two of the vaccines, the Novavax and Johnson & Johnson vaccines that were tested in the UK and South Africa, where the two of these prevalent new variants are circulating. And what we know is that both of the vaccines are effective against the variants, the UK variant and the South African variant. Now, that said, they're not as effective against either of the variants as they are against the more common variant. The UK variant seems to be much less of a concern. The efficacy went from 96% down to 86%, which is still very, very good. South African variant is more of a concern. There, the efficacy dropped down to about 50%, which is still good, but it's more of a concern. And I know that several of the vaccine companies are now modifying their vaccines to address that efficacy and try to improve it by incorporating the South African variant spike into their vaccines.
Absolutely. Thank you very much. Jason 𝐓𝐴𝐶𝐞, obviously now we're seeing that we're starting to expand the people who are getting vaccines into older parts of the population, and obviously that will continue to expand. But as that happens, I mean, is there going to need to be a change in the strategy for how you schedule and deliver vaccines? How are we going to manage that as we expand the parts of the population that get it?
Yeah, absolutely. So as we expand our age groups, we know that there's going to be different needs coming from these community members and residents. Obviously, there's a big uptick in just the sheer number of people that'll be coming through. So we know that there's going to be more 45-year-olds lining up than we do have 75-year-olds. So we're going to be looking at more of that mass vaccination that we saw before, but also having to still continually recognize those at-need populations and those at-risk populations that we have to address throughout this process. I think there's a lot of opportunity that we can do as we expand on the populations. We can partner with local businesses and organizations to try and bring the vaccine to them. Obviously, we know we're going to have to look at off hours, as there's going to be parents that are coming to get vaccinated after a child gets out of school, or they still may be working, whether it be at home or in an office. We do recognize we're going to have to change our strategy a little bit to address the different populations as they come on board.
Sure, absolutely. Thank you. Dr. Smith, I'd like to come back to you. We've had a request for a kind of clarifying question, if you will. And when we were talking about double masking, we had a question that asked, is there any harm in people out and about double masking just to add that extra precaution? Is there any downside to that? Or is it fine even if it's just something for reassurance?
Yeah, that's a great question. So there is no downside to double masking on your own in public at this point. We know that it's a little bit more cumbersome, but if you have access particularly to a medical mask, the proper sequence that has been posed based on one small study that was, again, not in a real world use situation, was they placed the medical mask underneath the cotton mask or outer mask, again, to have that medical mask closest to the source, your nose and mouth. So no downside. The only downside for you is that you're actually helping everyone else, and it's not the reverse. So everyone kind of has to do it to get the same benefit of source control, but you would argue, again, you're going to have some additional benefit of what the air that you're breathing in and reducing potential viral particles in that air as well.
Absolutely. And if there were ever a time for increased empathy, I'd say that time is right now. So we could all do more to help our fellow human beings. Professor Montefiore, I wanted to come back to you, and Dr. Smith, I'd love for you to weigh in on this too, if you have a perspective. Is there enough evidence yet from the United Kingdom and South Africa variants and others to know, hold on a second. Sorry, pause, I lost the question there. Restart. The North Carolina governor and the state education leaders are pushing for school districts to reopen for in-person instruction. How should the presence of more contagious variants weigh into decisions about reopening, whether at schools or anywhere else? Is there enough information to consider them?
So I'll start by saying that, first of all, neither one of these variants seem to be very prevalent in the United States. they're all found here, the UK, the South African, the Brazilian isolate, and of course, the California one. But so far, their prevalence has been relatively low. That could change over time as genetic surveillance increases and as the virus has more opportunity to spread. But given the low prevalence right now, I don't really consider them to be that much of a concern in most of the United States. There are a couple of hotspots right now, Southern California, Southern Florida, where the UK variant, which is less of a concern really, are becoming more prevalent. But for the rest of the country, so far the indications are that the prevalence of these new variants here is very low.
Understood. Thank you. Dr. Smith, anything to add there?
Yeah, I was just going to comment, this is our time to really double down on all the basic infection prevention strategies we've been taught. So trying to avoid crowds, physical distancing. I know there's a lot of work with schools going on to figure out how to sort of apply what's been happening in the healthcare setting with what's happening in schools. So spacing desks, having cohorts of kids. Some are doing screening testing programs. So I think with attention to detail and infection prevention measures, you can safely reopen businesses, schools, et cetera. We do need to keep our eye on these variant strains. CDC information forthcoming regarding this double masking in an unvaccinated population. Maybe this is an opportunity for additional measure to reduce transmission. So as Dr. Montefiore said, I think we have to keep our eye on the prize, and with the increased sequencing that's going on, we'll have more information of what to expect.
Sure, absolutely. That makes sense. Thank you both. Jason Civica, I'd like to come back to you. One of the things we're seeing, across the US and here in North Carolina and Durham County is the difficulty in reaching underserved populations with the vaccine. We're seeing numbers where in the Latinx communities, for example, they're disproportionately affected by the virus. And of course, the vaccination rates are low in many cases in those communities because it's hard to reach them. What kind of things can vaccination rollout plans do to incorporate that, address it, and try and reach those communities?
Yeah, I think this is actually a really important question and something that we all need to address. I think one of the first components, obviously, is the recognition of who these groups are. So you already mentioned the marginalized populations and the disproportionate infection rates that we've noticed within these communities. And I mean, that's a piece of just where they live. I mean, as they're shared housing, they're in close proximity. I mean, when we talk about as some of our mobility constrained individuals living in long-term care facilities, we really need to wrap our arms around these communities and recognize what are the individual challenges that they face, and then how can we address those needs. So I think, once you recognize it, the second most important piece is how do we actually engage the local leaders that are trusted and that could actually advise us on the best way to move forward in vaccinating these groups. So it's reaching out to your faith-based communities, any community-based organizations, community healthcare workers. All of these teams recognize the individual needs of these folks, and you try and bring them in. Here at Duke, we created the Duke University Health System Vaccine Equitable Distribution Committee, which is just a multidisciplinary group getting together at least once a week to basically discuss what are the specific challenges for our community and these individuals within the community. Even just thinking through, our deaf and hard of hearing, like what are the challenges that's going to be associated there? How do we bring education to them that is the non-traditional education that we're used to providing the rest of our residents? That's big. Where do we need to provide the multilingual services, and recognizing that some of those assets could be limited? Is there a way for us to combine our resources to one location and then work with, as you mentioned, the Latinx group and try and get those individuals to come to one site where we can provide an increased service? So within our community, we're really relying on these local leaders to bring us the information. They're also a trusted source of the safety and the efficacy. We've done outreach with them, trying to get pictures and just trying to, have them show, their whoever they would reach out to, that it is safe, that you can get it, that they've gotten it. Just trying to work through them and then partner with those local groups. I think that's the biggest thing we could do.
Sure, absolutely. Thank you. We've had a question come through the Q&A. Dr. Smith, I'll pose this to you, and Professor Montefiore, if you want to weigh in, that's fine too. Somebody asked, is it true that if you've already had COVID, you might only need one dose of the vaccine?
Yeah, very good question. So if you have had COVID before, as with many of our answers, it depends. Some studies out there have shown that if you had asymptomatic or mild infection, you will have lower levels of the important neutralizing antibodies that later protect you against seeing COVID again, versus more severe infection. So some people have said, wow, if you already had COVID, why don't you just get one booster vaccine? And will that equal, enough protection as the two, in the series that are currently available to us? And I think the answer is we don't have enough data to say that that's safe. I think we look to our CDC and other scientific experts to help advise us on that. But I think for now, sticking with the original plan of 2 doses of the vaccines available for maximum efficacy is a good strategy. And we should continue to work with that in mind.
Yeah, I would agree with this. We don't know yet whether or not one dose of the vaccine in people who are previously infected is all that you might need. But what we do know is that 20 to 30% of people who've been infected and recovered have low levels of antibodies, particularly neutralizing antibodies, whereas almost everyone who gets these vaccines have high titers of neutralizing antibodies, especially after a second dose. So, I think for now, in the absence of additional information, the best policy is to receive these vaccines and to receive both doses of them for the vaccines where 2 doses are indicated.
Sure, thank you both for that. And there's actually a question that works as a follow-up here that I'd like to get both of your perspectives on. What do you think about the recommendation we've seen in some countries to delay the second dose of the vaccine so that more people can get the first dose? Can that kind of, in a widespread public health way, reduce the effectiveness of trying to limit the spread, or is it a reliable strategy?
Yeah, that's a question that's being hotly debated by scientists. I just got off a call before this one where it was being discussed by the WHO. There are no clear answers again. There's some concern that a single dose and low titers of antibodies might actually facilitate immune escape. On the other hand, there's certainly a benefit of vaccinating more people sooner to reduce the spread and to reduce the number of severe diseases. So it's a really good question. There are no clear answers right now.
Sure, thank you. Dr. Smith, anything to add? Sorry, go ahead.
Just going to echo what you said. I think hot topic, lots of great, interesting discussion going on. And again, theoretical, lowered immune response versus more people getting it. What does that mean in terms of the overall severity of disease for people and the number of people infected? So I think we'll be interested to see where this discussion goes.
Absolutely, thank you. Jason Zyvicker, I'd like to come back to you and follow up a little bit on your last answer, where you talked about the importance of engaging local leaders to reach communities. And one of the things that we've seen is there have been occasions when people have been vaccinated kind of as an ambassador, whether it's a famous person or whatever. And there seems to have been some pushback where somebody sees maybe somebody who is young or not especially vulnerable getting vaccinated. But of course, the argument is this is a person who can convince lots and lots of people to get vaccinated. Do you think that that kind of approach, that kind of PR approach is ultimately effective, or do you think it can sometimes hurt because people see people getting vaccinated that they don't think should be jumping the line, so to speak?
Yeah, from a personal opinion part, I can see where it is controversial. I think that we have seen the use of ambassadors before, even with our flu shots when we do that annually, and it is beneficial. It is that voice telling someone, and we have to recognize that there is fear out in the community about this vaccine, or maybe distrust, whatever the word is. But I think those local ambassadors can help. That said, there is the other argument that maybe you don't fit the age group, or are you not, qualify, or are you not in the eligibility for receiving the vaccine? So I can understand both sides of it. What we have tried to do here at Duke is ensure that the ambassadors that we find do meet the criteria that the state has provided us, and all that in every chance that we can. But I do understand the frustration from some, but recognizing that we really do need to have those outreach partners, and that is one mechanism to be able to do it.
Absolutely, thank you. Dr. Smith, I'd like to come back to you. We've had a question about airplane travel. So, the current CDC guidelines for suggest, homemade cloth masks could be enough for airplane travel. But given the risk, the rise of multiple and more contagious variants, what would be your recommendation for somebody that was considering air travel somewhere? And what do you think would be the sensible recommendation for that?
My first recommendation is to question, where do you really need to go where you're trying to go? And what, is that necessary, or can it be delayed? That's probably the best move. But if you must travel or you're going to travel, my recommendation would be to wear a higher filtration efficacy mask, translated into, if you have access to the more widely available KN95 or an N95, that's what I would be wearing. And then I would also, you could wear eye protection. Depending on what people are doing on the plane, some people are not wearing their masks, they're eating and drinking on the plane. If I were to travel somewhere, I'd be wearing my N95, my eye protection, and I would not eat or drink on that flight until I could physically distance from other people. The last thing that I've heard from some of our experts in airflow and HVAC is that you should put the fan directly blowing at you based on how air currents work. So that's how I would fly if I were to fly, but I would really question, do I need to go where I'm going? And what am I going to be doing while I'm there? Am I going to be mixing with another household or outside of my household unit, thereby increasing my risk of being exposed to COVID or exposing that person to COVID? There's really no safe, travel at this time that's 100% risk-free. So just stay safe out there and be sure you're doing all those things once you get to your location, if you must arrive somewhere else.
Absolutely, thank you. Professor Montefiore, you mentioned at the beginning how viruses mutate. That's what they do, and this was expected. That being the case, does the fact that we've seen these variants now, does that suggest it's more likely that that COVID-19 is going to be like the flu and is going to be seasonal forever and something that we have to roll with, or does it not necessarily mean that at all?
Well, again, we don't have the answers, but it's certainly possible. The biggest concern right now is that the virus will mutate again into something that's even more of a concern than the current variants are. And the only way to prevent that, or try to prevent it, is by doubling down on all of the methods that we have, wearing masks, social distancing, and everything else to reduce the possibility of exposure, and getting vaccinated, getting these vaccines rolled out, and people receiving the vaccines. So, we need to stop the virus from replicating. Again, the more it replicates, the more opportunities there are for it to mutate. And so by stopping this virus from spreading, you're going to slow down its ability to mutate and evolve into something that could be even more of a concern than the current variants are.
Absolutely, thank you. And related to that, Jason Zyvica, I'd like to come back to you. We've talked already about how obviously the people who are getting vaccinated, the number of people, the types of people is going to expand. And one of the questions that we've had here is to what extent sign-ups can be a barrier to access. For example, if people are having to sign up online, then that actually is going to limit some, especially lower income communities. How are you guys thinking about the sign-up process as regards a way of getting people from wanting the vaccine to actually getting in and getting the jab?
Yeah, I would say that this goes back to us just having a multifaceted approach and recognizing that one solution is not going to meet everyone. So obviously, the easiest and quickest way for us to have the sign up is to do something online. We've obviously stood up our call centers to be able to take these calls, but not stopping there. We have actually dedicated percentages of our slots to, as we talked about before, our historically marginalized population, we are basically working with the community leaders, allowing them to schedule those appointments to come through. And you're working with a church, recognizing that sometimes the churches have their own transportation. we can say, all right, we're going to give you 20 time slots at 3 p.m. on a Friday. You can go ahead and fill them, and that can help alleviate some of the barriers that we would traditionally come into with our online portal or with our call centers. We actually have also tried to work with our local community health center by providing staffing into them, so that way they have that direct outreach and they have that already pre-designed and existing connection with the community. So really just trying to have a multifaceted approach and look at unique ways to help people. One of the things that we're actually starting to work through now is for our homebound and highly isolated patients, those folks that really actually can't even get out of their home. They really, they might have internet access, they might have phone access, but when they call a call center talking about their barriers, they have really limited ability to receive help. So how do you work with a group like a Meals on Wheels or other non-traditional group to recognize who these people are and not wait for them to come to you, but for us to actually reach out to them and figure out how we get scheduled appointments and how we get them vaccinated. So I think it's, again, just we can't be locked in on the one approach and the one method by which we allow for scheduling and access into the system. We have to be multifaceted and be able to adapt as new challenges come out.
Sure, that makes sense. Thank you very much. We've had another question come through the Q&A. Dr. Smith, someone wants to know, I mean, obviously, ideally, if you get both shots of the vaccine, you get them on the correct schedule. But somebody wants to know, is it worse to get your vaccine doses too close together or too far apart, and why?
So this is one of those somewhat data-free zones where we can just say traditionally what might be better or worse. I would say it's probably better to get them too far apart than too close together. And there's some guidance for people who just had COVID in between their first dose of vaccine, then they got COVID, and some new guidance that's trying to decide what to do with these folks. But again, the why is a little bit more challenging. Again, you want enough time for your I won't be as good as Dr. Montefiore in explaining this, but you want to give your body time to do all the fancy things that it needs to do in terms of making memory, B cells and helping your T cell response. The second dose of the vaccine is really what helps your immune system refine its approach to when it sees this virus again. And so you want it to happen in the correct time frame so that the first dose has done its thing, and then the second dose. I don't know if Dr. Montefiore wants to expand on that a little more eloquently.
Yeah, I will a little bit. So first of all, I think it's much better to have a delay in getting the second dose rather than getting the second dose earlier. As Dr. Smith was explaining, typically the way the immune system works is you're exposed to a foreign pathogen, your immune system kicks into gear, and then it'll calm down. And that calming down period is actually very important for it to prepare itself to come back and attack even stronger when it sees it again. And so that's what we want, is a little bit of a calming down before you see the vaccine again, the spike protein again, so that you have all of these immune cells built up and they're ready to take off and generate an even stronger response. The interval for vaccination in the case of this coronavirus is actually very contracted, 3 to 4 weeks. That's a very short period of time. Most vaccines are where there's more than one administration. It's usually several months in between. I believe the vaccine manufacturers contracted that period of time for the phase 3 trials so that they could get an answer quickly, because we needed a vaccine really soon. And they worked. So we know that interval works fine. It also comes down to how long that spike protein that the vaccines are made out of are present in the body, so that the immune system has a chance to respond. If you get these vaccines too close together, get the doses too close together, then the total length of time that the spike protein is in your body for the immune system to respond to it is shorter. So it's definitely better, in my opinion, to wait, if you have to, a longer time before getting the boost and getting it sooner.
Absolutely. Thank you both for that. And Professor Montefiore, we've got a related question to that for you, which asks, is there any reason to think that lingering immunity from having COVID recently could provide any protection from the variants?
So scientists are studying that very closely right now. And they are identifying cases of reinfection where people who recovered from infection with the common variant are now getting reinfected with one of these other variants that are less susceptible to the pre-existing immunity, especially in the case of the South African variant. Those cases are being identified. How much more prevalent they are than reinfection with the common variant is unclear. Mostly because where those studies are being conducted, the common variant isn't very prevalent anymore, so it's not possible to get adequate information. But that said, I find it very interesting and encouraging that if you look at the rate of infection, the number of daily infections in the UK and in South Africa, where they have these new, more contagious variants that partially escape immunity, the number of daily infections has gone down sharply over the past few weeks. So I see that as a very encouraging sign that the presence of these variants is not necessarily as devastating as you might think.
Sure, thank you very much.
There is still increased risk with these variants. We can't let our guard down. We need to be even more vigilant. We don't want them to spread.
Absolutely. Now certainly does not seem the time for anybody to let their guard down unless they want to get hit with a haymaker. Jason 𝐓𝐴𝐶𝐞, coming back to you, we've had a question come through for you, and it's a big and a broad one, but it asks, what do you see as the biggest challenge for the kind of vaccine, the practical vaccine rollout effort over the next 3 months? What's the biggest thing on the horizon for you?
I think the answer is going to be twofold. Obviously, one of our biggest challenges right now is the supply chain. We're trying to provide, the best service we possibly can to our patients in the community. We recognize that supply chain nationally is still being kind of flushed out in the process, and then it comes here statewide, and trying to make sure that, we're providing enough supply to, the more populated areas, but also recognizing that there's more rural areas that are going to need to be addressed and need to get supply as well. So we're trying to kind of balance our scheduling process that we talked about before, along with the type of supply that we're getting, but also recognizing that that's fluctuating. When you're in the operations, it's great to see the reaction from some of our patients that get to be signed up for their vaccine. Their day is here and they are excited to get that. But then when you have to call and cancel their appointment, that's where you're going to have a pretty big letdown. So we are doing our very best to make sure that we are not canceling any appointments if we can. But I think it's the balance of that supply chain and recognizing that we are going to have a fluctuation in the supply that we get over the next couple months. I think it's, excuse me, also recognizing that we have a run on the vaccination supplies like needles, alcohol prep pads, all of these items, prior to the distribution of the vaccine and locally or within the health systems themselves, there's a run on all these supplies. So it's making sure that you're proactively working with your supply chain leaders and vendors to make sure that you do have ample supply, or what are the alternative products that you can use if there is some type of shortage, and just being proactive in that. So that would be the first piece. I would say that the second piece that I think is going to end up becoming challenging in true transparency is our staffing. Our staff are tired. We've been at this for about a year now. And, we've been obviously taking care of the COVID patients that are coming into the hospitals and into our primary care clinics for routine care and for inpatient care. We've been testing, we've been doing the swabbing, recognizing that our staff have gotten sick and that they've had to go out. Obviously the stress of the pandemic is not immune to them. They're going to feel what happens at home with their children and with, what's going on with school. We asked that question before. So I think our staffing becomes an issue. Like we are tired. We know that the vaccination campaign is not going to be short-lived. We're not going to be out of this in a couple months. So it's making sure that you're supporting your staff and you're just continually checking in to see how they're doing and what type of resources they might need. I would also say that it's an opportunity for us to continue to look at non-traditional staffing areas. Our volunteers have come out of the woodwork within our community. We've actually partnered with non-traditional work organizations that they might have space that we can utilize, or they might have services that they can help us with that help try and take the burden off of the healthcare providers. So I think between supply chain and staffing, those are the two things that we're really going to have to focus on in the next little bit.
Gotcha. Thank you very much. Dr. Smith, questions come through the Q&A that I'd like to pose to you. And the question asks, should there be a medical grade mask mandate, for public out and about in order to combat the variants? Are the current CDC guidelines enough, do you think?
Great question. So that's kind of the active debate that's going on. Should we just preemptively mandate 2 masks? I feel like some areas are just getting around to 1 mask. And I've always said the mask that someone wears that's well-fitting is a great mask. And so again, focusing on getting the first mask to be correct would be great. In addition to still encouraging people to avoid crowds, social distance, don't mix with folks outside your household pod. Again, more to come. I know that some have predicted that the UK variant might be our dominant strain sometime by March. I think as we see what's happening over the next few weeks, that'll inform what CDC decides on this. If we see continued and sustained decreases in our daily case counts, that's a really good sign that we're seeing the light at the end of the tunnel. Again, can't let our guard down for sure. Continued monitoring, continued infection prevention measures. But at this point, it's one of those things, it depends. For me to tell our whole healthcare workforce, now you got to wear 2 masks and your face shield and all of this stuff, as Jason just alluded to, that's actually a huge burden. And where we have a very controlled environment with all of the infection prevention measures strictly enforced, I think that would be a burden potentially. Again, we have said it's optional for our healthcare workers if they choose to do that. Again, in the spirit of helping others, it might help you a little bit as well, but in the public, it might make more sense. And again, many people are like, well, what are you going to do when you go to the grocery store? I'm going to still, at this point, I'm wearing my 1 mask. But I'm also I've had the privilege of vaccine at this point too.
Sure, absolutely. Thank you very much. And I would like to add that if the UK variant does become dominant, I had nothing to do with it. I haven't been back to the UK since before the pandemic hit. Professor Montefiore, I would like to come back to you. And we're kind of staying on this topic of letting guards down. And we've had a specific question. After vaccination, is there evidence that you can still be exposed to COVID and then carry it and transmit it to others? Or do we not know?
That's a good question. And a lot of people, myself included, are very anxious to get an answer to that question. What we know about the vaccines right now is that they're preventing symptomatic infection. That was the end point in the trials. We do not yet know whether they're preventing infection altogether. Those data will come later on, hopefully pretty soon. But there's still the risk that the vaccines preventing you from having symptomatic infection, you might still be infected and capable of spreading that infection for some period of time, most likely a shorter period of time than if you hadn't received the vaccine. But again, there's also a possibility that for at least some period of time when the immune responses are at their strongest, that these vaccines are preventing you from getting infected altogether. We just don't have that answer right now.
Sure, thank you very much. And also to follow on to that with the guard dropping question, do you think that there's a risk that as more and more people get vaccinated, that society as a whole might let its guard down a bit too soon and feel like we can return to normal because most of us are vaccinated, and then that poses a danger of another surge? Is that a legitimate risk?
Yes, it is. We have to remain vigilant until we really turn the tide on this pandemic. It's not an issue of whether or not an individual has been vaccinated and protected. It comes down to what's happening at a society level. And only when the number of infections and the risk of acquiring infection gets low enough at a society level will we be able to finally take our masks off.
Sure. Is there any sense of yet what that level is? Because obviously, as we move closer to what people hope will be reopening, everybody will probably start to focus on this number more and more in terms of new cases or reinfection rate. Are there numbers that you scientists are looking at saying, well, this is where we think will be the safe level to begin to return to normal? Or again, is it too early to say?
There aren't any numbers that I'm aware of. People haven't been talking about that yet. I imagine pretty soon we will be hearing what the computational people are recommending, but I haven't seen any numbers yet.
Sure, thank you very much. We've got a question come through the Q&A for Dr. Smith. And Jason 𝐓𝐴𝐶𝐞, if you've got any perspective on this, feel free to weigh in also. The question says that early in the pandemic, there were reported shortages of medical masks for healthcare workers. Are these shortages no longer an issue? Are there sufficient supplies to ensure frontline workers have access to the infection prevention measures that they need?
Absolutely right. We need to keep our eye on the supply chain. And so there's a big difference between having enough medical masks for all of the hospitals out there versus having a medical mask for every single person in our country. That's a big burden on the supply chain, and that could cause a run on medical masks. I know there are several iterations of people's cloth masks that have the ability to insert some type of filter. And so I wonder if there will be some suggestions on how you could make simple modifications to cloth masks to make them more efficient at filtering particles. But I don't think we're out of the woods on any type of medical supply, whether it be testing supplies, reagents, masks, gloves, gowns, N95s, needles, alcohol swabs, everything you can think of. It all is in demand at the same exact time. So again, I'm really curious to see what will come out of CDC because unless the mask makers have drastically ramped up their supply of masks, we would not have enough for everyone.
Yeah, I would agree with Becky. I think we could say that the demand and the issue that we saw early on in the pandemic has decreased where we really didn't have masks. I mean, obviously now I think the supply chain is still constrained. We still have to pay attention to it. It has gotten better. The supply chain has gotten better, but I would definitely say that, you know, we still have to be continuously monitoring and understanding where we're at with the supply chain overall.
Sure, absolutely. Thank you. Professor Montefiore, we've had some questions about vaccination among children. What do you know about where things stand with the potential for an emergency use authorization for a vaccine for children? Should we expect that by this summer there'll be mass vaccinations of children, or is that not a realistic timeline? What do we know right now?
So that's being addressed right now. The phase 3 trials that have been conducted to date have not involved children. So, you know, the concern there is, will the vaccines be just as safe and effective in children as they are in adults? And so those tests are being done now. And, you know, hopefully we'll hear what those results are soon. And the vaccines will, you know, demonstrate adequate safety and efficacy in children as well.
Sure, thank you. And as a follow-up to that, given that obviously children aren't part of the current vaccination rollout, is there a risk that they keep spreading it to adults and reduce the effectiveness as a vaccine as a whole while we're waiting for everybody to get it?
Oh, yes, absolutely. It's going to be important eventually to be able to roll the vaccines out to younger people as well.
Gotcha, thank you. And Dr. Smith, a related question for you regarding masking. The suggestion is, should children under 5 need to wear masks? You know, we've seen so far that obviously people don't suggest that babies wear masks for obvious reasons. But at what point do you think that it's both reasonable and advisable for children to start wearing masks if they're out and about?
Yeah, I've actually been thinking through our whole, what I call the COVID infection prevention bundle, and how we would sort of reverse the rollout of all of the measures and what's the most impactful measure. And I think the last thing to go is masks. I think we need to have, like I mentioned before, clear decreases in daily case counts that are sustained. We need to have more awareness of what are the circulating strain types in our country and how has that impacted our daily case count. And only then can we start saying, okay, now we're going to relax perhaps some of the social distancing measures, but still try to wear masks. And then again, sort of systematically go through each one, remove them in a controlled way, if you will, and then see the impact on daily case counts. But I wouldn't just say like one day we're done with this whole bundle. I would want to see it rolled back in a very careful way. I think you alluded to what are those magical numbers? As with COVID, like there's just curveballs all over the place. And it's one of those things where you kind of know it when you see it, but you're still monitoring closely afterwards because you could be wrong. This is a new pandemic. We're learning new things every day. We're seeing variants. We expected those. I suspect we're going to have, at least based on these new variant strains, Moderna's already working on a booster. It's just sort of panning out how we thought it might. But again, that all leads to a little bit of concern for folks. But stay tuned is what I say.
Sure, absolutely. Thank you. And Professor Montefiore, going to the other end of the spectrum, obviously lots of people have not been visiting elderly relatives because of concern over that. The question is now that as more elderly people are vaccinated, does that mean that it would be safe for people to go and visit those elderly relatives once they have been vaccinated? What's the kind of guidance about continuing to take precautions around elderly relatives once they have been vaccinated?
Yes, well, again, just the fact that you've been vaccinated does not mean that you can relax your prevention measures. Until this pandemic is really brought under control, it's going to be important that people remain very, very vigilant in their prevention measures of wearing a mask, keeping their social distancing, washing your hands frequently, avoiding large group gatherings, and getting together with family members who are at greatest risk.
Sure, absolutely. Thank you. We are getting close to time. I'm going to whiz through as many questions as we can before we wrap up. And another question here, actually, and Professor Montefiore, you're probably best placed to address this if possible. Says, with an estimated 100 million Americans already having contracted COVID and another now 26 million partially vaccinated, is America any closer to herd immunity? And how do the new variants threaten that potential for herd immunity?
Yes, two very good questions. It does look like the United States might be reaching herd immunity. Again, that's based on looking at the number of daily new infections. It's been going down sharply over the past few weeks, which I find very encouraging. But one of the biggest concerns is that a variant like the South African variant, the Brazilian variant, the California variant might actually slow down our progress towards herd immunity because of their partial resistance to that immunity and the risk of a new variant emerging that's able to evade that pre-existing herd immunity even to an even greater extent. So it's very important that we, again, remain very vigilant in our prevention measures and that we get people vaccinated so that we slow down the spread of this virus and its ability to replicate and continue to mutate.
Absolutely, thank you. So we are getting close to time, and I think we have gone through most of the questions we had. So I have one final question that I would actually like to pose to all three of you. And it's a fairly simple one, but hugely important, since vaccine hesitancy is one of the biggest issues that we could face in getting out of this. And that question is, if somebody comes to you and they are nervous or hesitant about getting the vaccine, what would you say to them? Dr. Smith, we'll start with you.
I would say to them, the vaccines were very rigorously tested for safety. The data is publicly available. They did a very good job of recruiting patients from different races, ethnicities, ages, and all of the data is very compelling that they're safe. As you've seen, we've now vaccinated over, I think, 26 million Americans, and we're very closely following what's happening with that. The CDC has a nice tool where you can sign up to report any of your own personal side effects. So I think we would be seeing a signal if there was any safety issues that weren't caught by the clinical trials. And I feel very comfortable having conversations one-on-one with folks saying, I feel very, very comfortable with this vaccine and recommending it. And the last question that I often get is, gosh, should I, if posed with the choice of getting one vaccine over the other, my response is get whatever one is being offered to you the soonest, even if it has a purported lower efficacy rate. That will afford you protection sooner. As you've seen, many of them, even the ones with the lower overall efficacy rate, prevent against severe disease and hospitalization. So whatever one's being offered to you, go get it. And it's been studied well.
Thank you. Jason Zywiecka, anything to add to that?
Not really. I mean, I would say coming from the non-clinical and non-scientific mind, the only thing that I would say, from a personal standpoint is don't be afraid to talk about it. I think the fears that people have are real. And if you do have fear or concern, reach out to your doctor, talk to someone who's already got it. I think we're all going through this together. It's just smart to open that conversation up and allow yourself to get the feedback versus harboring it inside and feel like you can't ask important questions that's on your mind. So that's the only thing that I would add.
Absolutely, thank you. Professor Montefiore, what would you say to the vaccine hesitant?
Well, I would remind them again that these vaccines have been shown to be very safe and very effective. And also, someone once said that the most dangerous vaccine is the one that you don't take, because then you leave yourself susceptible. It's much better to have some discomfort from getting this vaccine than getting infected and having the risk of serious disease. People also have a social responsibility, a civic responsibility, I believe, to get the vaccine in order to bring an end to this pandemic.
Absolutely, thank you. And I think that's the perfect place to leave it. Thank you, everybody, for joining us. Thank you to our panelists, David Montefiore, Becky Smith, and Jason Zywiecka, for sharing your perspectives. Next week, we'll be talking about the merits and the risks of reopening K through 12 schools. If you'd like to be notified of that and other upcoming briefings, please email dukenews@duke.edu. In the meantime, please stay well, wear as many masks as makes you feel comfortable, and get vaccinated when your turn comes. Thank you, everybody, and have a great day.
Thank you.
Thank you.